All right. Great to be here again, Dr. Amols.
Should be. I am trying to go live on this other one here. We'll give people just a second here to get on. There we go. Yeah, it's awesome to be here.
Yeah,
it was definitely a fun show last time, and I'm looking forward.
We had some great questions last time, and I'm just always so impressed by how incredibly knowledgeable everybody is that is, one of our patients. They really do their reading, and it's just impressive to see how much they understand some of this stuff.
Yeah, I mean, I think the great thing again about this is that it's allowing people to ask questions. I mean, it's amazing how we think of things and how, the questions we have, and we think the questions they have, and then they come out with a question. We're like, oh, wow, didn't even think that would be a question. So, yeah, it's really exciting. Well, before we start, just to make sure everyone knows, if you are, coming to watch this, please watch it from one of the social media sites. The stream link is mainly for people who want to be on the show and who want to ask questions. Once you ask those questions, RA will, at that point, kick you off just so that way someone else can come on. There's only so many spots for people. So we talked about last week, we were going to start off this show by talking about a topic. And last time we talked about PGT. This week we were going to talk about PRP, rejuvenation of the ovary. And we kind of took like a little bit of a pro-con point where I'm going to be talking about the pros of it. And Dr. Salem's going to be talking about the cons. And I think it's important to understand that neither of us are really pro or con for any of it. We think on both sides of it, there's some good arguments, but we just wanted to kind of present the two sides of it. And so I'm going to start first and go over the pros. And then afterwards, he's going to talk about the cons. So when it comes to the pros for using PRP treatment is, if we look at it from the standpoint of whenever you're doing anything, you usually have to have a theoretical reason that will actually work. So there has to be some plausibility to it. And if we look at PRP, what we find is that we know it does benefit. It does rejuvenate certain tissues. So it's actually used in sports. It's used to help things heal. And that's because the platelets have properties that allow for neovascularization, meaning to create new vessels in certain areas, and even reparative mechanisms. And so we know it should be able to help. And so one of the pros of using this is that we know it should help. And we're going to talk a little bit about the studies, whether it shows up, but there are some studies that show some benefits. So for example, there are mice studies that have shown that mice that have been purposely caused to develop menopause through basically chemotherapies have had improved fertility after using PRP treatment. There are multiple studies out there, none randomized controlled trials, but there have been multiple studies out there that have looked at women given intra-ovarian PRP. And what it's shown is a lot of times their AMH levels will go up, their FSH levels will go down, and even antral follicle counts can actually go up. And so we can make that next conclusion that if those things are improving, then potentially we should be able to get more eggs and potentially be able to get a better chance at pregnancy. And so when you look for the arguments for it, I think you can also make the argument that what is there to lose? Very few people are taking this who don't need it. So if someone comes in who's 25, who's already making 18 eggs, they're not really asking for PRP therapy at this point for ovarian rejuvenation. But people who are at that point at the end of the road and they're like, I have no other options, I've tried everything else. I guess the question is, what's the harm? And so one of the pros for taking is that there appears to be plausibility. There appears to be studies showing it. We know that PRP definitely helps with things like blood flow and repair. And so for these women who are at that last shot, it's not unreasonable to try, regardless of some of the studies saying that, it may not benefit. Right now, there's at least some plausibility that it could, and it seems like it's a pretty good thing to at least try. And so I'm definitely interested next in hearing what Dr. Salem has to say about the cons, and we'll go from there.
Yeah, no, I gotta admit, I gave you the hard one, right? So the pros are hard whenever the body of evidence is still developing. And that's kind of where we're at, I think, with this, right? So I think that, we have these early studies, and some of them are pretty interesting, right? So a lot of them in mice are showing, with PRP in certain populations with severe DOR, or in that perimenopausal window, you can have increased, growth factors leading to increased estrogen and progesterone production within the ovary, increased estrogen receptors. So it makes you think like, maybe there's something here. But just like any good doctor tends to try to do, we at least try to, have all the evidence that we can and say, is there enough evidence for saying that the benefits outweigh the cons? And so I guess I'm responsible for talking about the cons. And, there are some, there's definitely always some whenever you do a medical treatment. So, the way that PRP is generally given, not always, there's different ways, but it's into the ovary. So you have to go under anesthesia, and you have to put a needle into the ovary, and you have to kind of make a couple pokes into the ovary, and you put the PRP directly into the ovary. The other thing is that comes with some of the risks of, generally the things we would think of a retrieval, right? So, maybe a very, very small risk of infection, or a very, very small risk of bleeding. They're very small risks, but they're not zero. And then, the last thing that I keep coming back to is that, there's been a lot of studies done on it in the lab, on mice, on some other models. And those studies are really surprisingly good. But my patients aren't mice. And so I have to get the human data to tell me like, hey, this is pretty good. This thing really works on humans. And I just don't think we're quite there yet. And we might get there. And it's really exciting that maybe we find a group of patients that really benefits from PRP. But we still haven't, in my opinion, found that group perfectly. And once we do, I do think that there's going to likely be benefit, but we're just not there yet. So I don't know if it's prime time 100% for everyone. There are those, let's call them edge cases where, just like you were talking about, Dr. It was like, people have tried a lot of things, and this is kind of their last shot at it. And they want to say, well, I don't want to leave anything on the table. Maybe there's some early data around this. I'm willing to basically try it. I'm willing to kind of experiment here. And I think that's okay in certain cases, as long as our patients really know that that's where that lives. But I also, want to just throw out that the treatment is often not free. So outside of a clinical trial, you have to, pay for all the procedures in the lab and the procedure to do the mock retrieval kind of thing where you inject the PRP. And so there's this cost component as well. And in some places, I've noticed that this can be really expensive. It's kind of like, wow, I've seen some really high prices. But I don't know. That's my spiel about the cons. I'm really excited to see what comes in the future with it. And I think there's going to be a group of patients we can really help with it.
Yeah. Yeah, I mean, before we started talking about this, and again, you and I share very similar views on this with regards to it's very exciting. Anytime we can do anything to help, our patients, it's always exciting. But the question is, how much are we helping, and how much could we be hurting? And like I said, the pro side is that I do believe there's a point where you should always be able to try something as long as there's no harm. And like you said, the harm does seem to be a little mild. It's a little harder on the pocketbooks. But what about the thing we talked about earlier, which is the patient population? Because I tend to find that the patients coming in aren't always the best candidates, meaning, if someone's 25 years old and has diminished ovarian reserve, if they are able to even make an extra egg, that's enough to potentially get them to success. But I tend to find that the people that come in are usually people who are so severely over, meaning, like, for example, not someone who just went into diminished ovarian reserve or just went into premature ovarian failure, but someone who's already been in the menopausal range for 5 years, and they're coming back for that, last hope, which kind of breaks my heart, because I know that population looks at the studies that say, oh, well, some women get their period back. But again, 5 years out and stuff. So I just wonder, what's been your experience too when it comes to people come for PRP, is it generally, are you finding too, it's people at that end stage, or is it people who, really might benefit from it more?
Yeah, no, you're totally right. And I mean, I wish that that would not be the case so commonly, just so that we could help a larger fraction of the people that want to try this. There is a sort of a point of, let's call it no return with some of these things, and we don't know what that point is yet, but we seem to be, most of the patients that seem to come in are closer to that point than that patient you were talking about earlier, which was a patient who's maybe in their mid 20s, and they just have a really low ovarian reserve. And there are some elements of why they have such a low ovarian reserve that aren't perfectly explained. And maybe this is something where it really helps them, but because each egg, in theory, is going to be a really high quality egg. And I think that's a group that may benefit, but the studies need to be done.
Yeah. There was a recent, well, I mean, I don't even know if it's been published yet, but there's that recent, it's called Revitalizing Female Fertility, Platelet Rich Plasma, Hyper Hope. And I don't know if you saw that was on recently, the REI, like, kind of Facebook group, they were talking about it. And, it was interesting. I mean, when you went through the whole thing, it was kind of talking about how there is some hope, but, there's definitely a lot of hype right now. And so one of the questions I saw someone was asking is what does PRP help with? And so although we just discussed talking about ovarian rejuvenation, I think it's a great question, is can it help with other things? The answer is yes. As I talked about in the pros, it's used in sports, is used to help with injuries in sports, and so that for healing. We tend to use it in several areas in fertility. The ones I know about, and the one that we use a lot, is for lining thickness. So people who have thin linings, people with Asherman syndrome, there has definitely been some studies that have shown some benefit there. When it comes to ovarian rejuvenation, again, another area we're just talking about today, that one's still a little less studied. Again, no randomized control trials for that. And in case people don't know what that means, randomized control trial means randomly giving it to everyone and then finding out who benefits and who doesn't, but they don't even know if they're getting the medicine. We don't even know. And so that way the study can't be biased and we know the results. But the other one that I saw, which I'm not as familiar with, but I did see some benefits, was in recurrent implantation failure. And so that's another area I see people using it. And, I was reading in that article, there was like one study where, I think it was like 18 out of 20 people ended up, having pregnancy. But, again, it's one arm of a study. It's not looking at, if on the other side, like, was it that or was it something else, just they were just better at doing transfers in that practice?
Yeah, yeah, very interesting with the uterine benefits there. And I would say there are a lot of studies there that are a little further upstream, I would say, right? So, or is it downstream? I don't know. It's further along. That's what we'll call it. And I do feel more convinced by some of those studies for recurrent implantation failure and how to use it there.
Yeah, I mean, I think that's one of the hard things about some of these studies, why it shows, when you don't do a randomized control study, you don't know what helped. So it's easy to say, well, it's the PRP, but what if they're just better at doing transfers? And that's why it went better, right? Or maybe they were watching things closer, checking hormones closer. So it's interesting. Like I said, part of me wants to make sure it helps, but on the part of me of being the physician, I also don't want to, recommend something if there's no proof that it works, because then I feel like I'm leading people down the path of false hope. And so I'm very excited what comes of it. Anything else that you think of in our field? I'm thinking for PRP treatment. Those are the only things that really come to mind to me.
Those are definitely the really big ones that come up. I mean, I know that in other fields they're using it for recovery after surgery, and this is one of those kinds of things gets my attention. Obviously, nobody's really doing the studies full out, but it does kind of pique my interest. Like, what if you have a quite invasive surgery for a fertility underlying fertility cause, and what are there any benefits of injecting PRP? And again, that's kind of from what I know, kind of a data-free zone.
Yeah, I mean, I think probably one of the biggest questions I ask all the time is, what can I do to help my ovarian reserve? And I think sometimes we put too much focus on the ovarian reserve. So, for example, I always explain to people, you can have a good ovarian reserve and not get pregnant, and you can have a bad ovarian reserve and get pregnant easily. Ovarian reserve is really just more of a measure of how well you'll do when you take medications. And so the interesting thing with the ovarian rejuvenation is, even when it helps parameters, does that really mean you're going to have an increase in live birth? And that's where we just don't have the data right now. Excuse me. Well, I think we've beaten this topic to death a little bit. And I saw one of the questions we answered. And so let's bring up Ari and see if there's any questions she has for us. And then we can kind of go over that. Let me pull you up, Ari.
All right. All right. Hey, so we have some in the private chat, but like you said, we've pretty much hit all of these on the nail. I guess the last question that came in from Tara on Instagram, it says, how many times would I have to do this to better my chances? And do you think it's really worth it?
Perfect. I'll let you start first, Dr. Salem, since I feel like I was talking more.
Yeah, no, I mean, I'm happy to. I mean, so again, because this is a pretty invasive type of procedure, the number of times that this has been done is kind of relatively limited. Some places will do it once or twice. There are some places that do it maybe, I think, 3 times. It's a pretty limited amount overall in these early studies and early protocols that have done it. Interestingly, there is also a difference in how much you inject. So I don't think the dust has settled on that yet either. Some people may inject a little bit more, some may inject a little bit less. So again, this is one of these things where we're just not sure yet. Some people have tried it under some protocols and they say, this is our protocol and it seems to work for us, so we're going to stick with that protocol. But to say definitively it's 3 times or something like that, I mean, I don't think we have the data for it.
Yeah, I mean, I can tell you at our clinic, we came up with a protocol looking at, other protocols. And, what we do is we usually do about 2 times whenever we are going to be doing it for a transfer to build up the lining. We usually don't do one early and then we do one a little bit later. I've seen some protocols where they'll actually give for recurrent implantation failure, they'll actually give the PRP 48 hours prior to the transfer. And again, that's even additionally with the other ones for building up the lining. With the ovarian rejuvenation, I've only seen people do it 1 time and then they look for the results in the study. So up to like 6 weeks or, out. I've never seen people do it over and over again, but I mean, I do know people will do it after a period of time. I believe the effects most say is about up to 60 days, 2 months. And then from there, I guess you have to redo it again. But as you said, there's no really good studies, so it's hard to really come up with a protocol. Everyone's doing different, trying to figure it out, and unfortunately, it's going to be hard to know. I think the second question part that Tara asked was, is it something that's worth it? I think that's a really hard question to answer because what is worth it for me might be worth it different for someone else, right? For 1%, that might be enough for someone to go, hey, I'm willing to pay that for 1%. I always look at everything from more of a standpoint of like cost effectiveness. And so if I go, okay, if I spend, I'm just make up a number, let's say it was $5,000 to do it. And there are some clinics that do charge a lot for it. And I could do 2 IVF cycles or IVF cycle instead of doing it. I may say, well, listen, if I can get multiple IVF cycles in, just getting the number of eggs might be beneficial. So if it can only double my eggs and I can do 2 cycles and, get double the eggs, I don't know if it's as cost effective, but I think if it's somewhere it's affordable and you tried other things, it's definitely not an unreasonable thing to try. Just understand going into it, this is experimental. It has not been proven. And, if hopefully if it works, it's either because of it or coincidence. So what do you have to say? I mean, what do you think? Do you think it's worth it? Dr. Salem?
That's a pretty tricky one, right? Because I think of it exactly in the way that you do, about this idea of value. You know, how much value is created by doing incremental things. And you know, sometimes there's a lot more value in just like you said, just doing another cycle of IVF, because you're going to get 5 more eggs and another shot at it. And if you know the price is getting very close to what you would be doing with PRP, and it's just helping you get, you know, an extra egg or two, you know, I don't know. And again, these are hard things to compare, because you know, value and cost effectiveness are hard things to compare at the individual level. They're easier things to compare when you talk about a group of 1,000 people, and then you say, well, obviously this is more value added to do this than this. And so with the individual, I mean, that's the difference between public health and medicine. You have to figure it out with the person that's in front of you, and use a shared decision making model to say, what do you think? Here's what I know. Let's make a decision together about this.
Yeah, no, I agree 100%. And one of the questions I was asked afterwards was, you know, how much does it cost, and do you have to go under anesthesia? So, I know of 2 ways that you can do ovarian rejuvenation with PRP. The first way is the one that's most known, which is going to be intra-ovarian administration. I mean, technically, you could do it without anesthesia, but I wouldn't recommend that. I think it would be very painful. So what happens is you do go under anesthesia, and then the needle's placed into the ovarian tissue under the kind of the tunica underneath it and placed in there. The second way does not need anesthesia, and that is where you go and you essentially put a catheter in the uterus, blow up a balloon, and then under high pressure, you push all of the PRP solution through the fallopian tubes around the ovaries, and then they kind of soak in it. And then that one usually is a little bit lower cost, and it doesn't require anesthesia. And the question kind of, and I'll let you answer too, because I feel bad answering this. I sometimes even wonder, like, if both should be, when you're talking about the different pricings and whether they work, I almost feel like the one where it's baiting it should be better than injecting it. Now, I know it sounds kind of weird, because you're like, well, man, injecting it in, that gets it right in there. So that's the best. But when you think about it, I mean, where do eggs sit? They're not inside the ovary, right? They're on the outside of the ovary. And so if it's baiting in it, and, you know, think of the ovaries sitting in the pelvis, they're going to be sitting at the very bottom with all this fluid there. It's going to be sitting there for hours and hours and hours. And so it's interesting. I mean, I just wonder what your thoughts are on that. I sometimes wonder if that could even be a better method, but obviously there's just not enough data out there to say what's better and what's not.
Yeah, that's right. And I mean, that whole environment is so important. It's not just the ovary. I mean, I'll give you like you know, we'll draw an example like endometriosis, right? So the endometriosis that is in the ovary is not the only endometriosis that can affect egg quality or can affect results. You can have endometriosis in the pelvic peritoneum, that place that you're talking about, that kind of potential space where you would put in the PRP. So, you know, there's a lot of biology, let's call it, that happens in that intraperitoneal space. A lot is absorbed. I mean, it is an incredibly complex space. And so I do think that could be a better option. Absolutely. And I hope somebody can compare them, say, here's a study with ovarian, here's a study with intraperitoneal, and follow people out until they hopefully get pregnant.
With regards to the cost, I mean, you probably know where the highest cost is. You were in San Francisco at one point. I mean, what were people charging for it out there?
Oh, it was insane. I mean, you know, you know, I heard numbers that were in the range of like, you know, $10,000-$15,000 when all is said and done, because it's never just the one therapy. It's all the things that, you know, might surround that therapy. But so that's one of these things where I'm like, boy, the value there is really called into question. And the cost effectiveness is really called into question.
Wow. Well, let's get Ari back on and see what other questions we have. I'm going to get Ari back on here. Hey, Ari.
Hey, guys. Hey. So we have actually 2 more questions on here. It's from Shauna on Instagram. She wanted to know, I think she missed her chance last week, but she asked, could you get their feedback on True Nitrogen? I believe it's a supplement. And then she also asked a question about IVC. If there's time, can you talk about the chances of implantation with a fresh transfer of IVC?
Yeah, absolutely. I'm not, and I'm going to let you, Dr. Salem, maybe take over here. I'm not familiar with, she says feedback on True Nitrogen. Is that like a supplement?
It's a supplement. It's a supplement that exists out there that's like a, NAD plus. It's a B3 precursor,
Gotcha.
I believe, vitamin
Okay.
B3 precursor. And they, it like increases the NAD plus levels over time, which is an antioxidant. And it's,
So anti-inflammation.
the theory is that it increases, exactly, like it improves the environment, just like all those things that we were talking about with improving the metabolic stress of that, ovarian environment. Now, I think this is a great question, both about NAD and also about supplements in general. The first answer, and I'll be totally honest, is I don't know. I mean, I have no idea if, True Nitrogen is very effective for IVF, or if it is, just one step above a sugar pill, right? And the reason I don't know that is that it's very, very, very hard for companies to do really good studies looking at just this one thing. And here's what I mean by that. You would have to kind of think of having a group of people that does the exact same thing as another group that just, the only difference is they take this NAD plus and the True Nitrogen. And then you could get a pretty fair comparison of the two. But, that's really, really, really hard to do. And so a lot of people are very interested in another concept. And I think this is kind of the more maybe impactful thing. And I think it's this concept of, health span and, one's healthy years of life. And I like to call the correlate of this, or kind of the thing that matters to me, the reproductive lifespan, right? About, how many years of good fertility are there? And is there anything that we can do to massively increase or decrease that? And I think this is a field of a lot of research. And we still have a lot of unanswered questions. And I would say True Nitrogen is on that list. Now, one other thing about supplements, I think that, there are many supplements that are out there that tout certain things. And I think that's great. And I think one of the things that we have to be careful with is that the supplement itself is manufactured in a way that it actually contains the thing that they claim has worked before. And so one way to kind of tell that sometimes is to look on the label and to see if it's been third-party tested. Does the product actually contain what they are claiming it contains? Because that would be the first question. If it doesn't even have what they're telling you it has in it, then game over. So that's kind of one way that I look at a lot of these supplements. And I mean, we could talk about supplements until tomorrow. And I'm very excited by some of the things that are coming out. But I think it's a place where we have to tread a little carefully.
Yeah. Yeah. I mean, you brought up the point with regards to if you look at a study and you're taking the human body, and this is the thing I try to always get across to people, is that you can do the exact same thing over and over and over and get different responses from the human body. And, you're thinking about all the things that people are doing. So even if you have people taking the same thing, is their ovarian reserve the same? The stimulation protocol the same, right? Is their environment the same? One's going home to, let's say, a smoker. The other one's going home, to this, health addict. Like, one's working out every day. I mean, it's so hard to do something like that. And I think if there's ever been a study that has proven to us that you can't look at cellular information to be able to determine what's happening to a body, was the Women Health Initiative study. I think that was one where, there was absolute evidence that estrogen helped heart cells. Wasn't even the question. Every single study showed it at the molecular level. But then they went and actually did a trial and then found out, wow, it actually increased the risk of heart disease in some of these people. And again, you and I both know that there's a lot of problems with the study and things like that. But the point is, just because something in the lab as you point out, just because something in the mouse doesn't mean it's always going to be in humans, and that's what makes it so hard. And so I always take the thought of, does it hurt you, right? Is it going to cause any harm? And I think there's some things we can just think it out and intellectually say, no, that's probably not going to harm anything. So no big deal. Go ahead and take it. I think one of my favorite ones is McDonald's French fries after a transfer. There's, a big push that helps you get pregnant. And I tell people, why wouldn't you want to eat McDonald's French fries? They're so tasty. So, I mean, why not do it? But you're right. I mean, I didn't even know of that. I've never heard of that brand or something like that. So thank you for at least educating me on that. And then I think you said there was a second question, Ari, was about the chance of implantation with a fresh transfer of IVC, correct?
Yeah. We have some rolling in. We have some more. So I hope you guys are ready for this.
Yeah, I hope that people feel like they can come on too and come live and talk to us.
Yeah,
So
guys, if you want to join in and talk with the doctors, go to our website. We have the join live and ask your question link, so you can come straight to our space on Yardstream. Let's see. Did you guys already answer the question about IVC and the fresh transfer?
we did not. So we can start that. I think, first thing is just explain what IVC is. So IVC is something that's, I wouldn't call it new, but there's a thing called InvoCell out there. And InvoCell is this device that allows embryos to incubate in your body versus in a petri dish. So with IVF, eggs are taken out, they're fertilized. The embryos then are in a petri dish and grow in there in an environment that mimics the inside of the uterus. And so we check temperature, we check the pH, and then we're able to look at those. When they're in this InvoCell, they sit in the vagina, which when you think about it, the vagina is internal, the temperature is going to be the same. It's not going to have oxygen. It's going to be very similar to the environment. And so when it first came out, it was only something that could be done to day 3. It has actually now been FDA approved to go to day 5 with the embryos. And so it's just kind of a different way to culture. Now, in the IVF way, we're able to culture and we can remove the fluid and put new fluid. We can adjust things. You can't do anything once it's in the body. So basically, for 5 days, it is culturing in its own fluid. And then what we do is we open it up. If we find embryos in there, we then put them back. So just so everyone understands what IVC is. I am not aware of any large studies yet looking at the success rate of using IVC. I've had the company tell me that they were having pregnancy rates of 70%, and that's just baloney. There's no way that a clinic is getting 70% pregnancy rates without doing testing when some of the best clinics in the world are barely getting 70% pregnancy rates. So I feel that's not very truthful, but you can cherry pick and make it sound better. I believe it's probably going to depend on obviously who's doing it. I think it's going to be, when you look at younger people, it's probably going to be pretty good, but it's such a different situation because when you're doing IVF, you're picking the best embryo. You look at all the embryos, you pick the best one. With IVC, you're just, hey, this is what we have. Sometimes you don't even have the best embryo that day. The best embryo could be a day later, but you're just putting back what you have then, and you put up the 2, and you could be putting back the 2 that aren't the best. And so I would say probably the pregnancy rate somewhere between maybe 30 and 40%, per embryo. It could be down to 20, 30%. Unfortunately, no one really knows. I know at our clinic, we've done fairly well with it. But again, the right patients, the right one. I don't know if you have anything to add to that, Dr. Salem. Like I said, it's I don't know of any actual data out there looking at it.
Yeah, no, I mean, I think that, I totally echo your thoughts about it being just a really different approach to treating infertility. And I think the key thing to get the high success rates is you have to, let's call it cherry pick the right patients, but it's a good cherry picking. We want the people that are going to get benefit from it to do it. And we want the people that it's kind of a waste of time for them not to do it, So, and there are many cases where, right, like very, very low sperm counts, really bad candidate for InvoCell, right? Things like that. And I got to tell you, I kind of cheated. I looked up, and you were absolutely right on those success rates, because I think you have a lot of experience doing them, and you're exactly right. There's the mean cumulative live birth rate per started cycle was quoted as about 29 to about up to 50%. But in another place, they say 40%. So you hit it on the money. Yeah.
I mean, I just based that off of just what I've seen at our place, experience. And you hit the nail on the head there. I mean, not everyone's a good candidate for this. And I usually see a couple people I think are good candidates for it. I think in my mind, the best candidate for this is someone who hasn't even done IUI. And let's say they have like their tubes are blocked, right? And they just want one more kid. And they're like, I don't want to go through IVF. I don't want to get my tubes reversed. I think it's a great idea. I mean, it's a very low cost option. It's like a mini IVF. And then the other place I think is like a lot with same-sex couples. I think it's amazing actually for same-sex couples, because in that situation, you don't even have infertility. And no one wants to waste all this time doing IUIs, which is expensive because the sperm costs you on every single one, an arm and a leg. So you do 3 IUIs, you're looking around over $6,000-$7,000 because, you're paying for sperm, and it's not even Brad Pitt sperm. So I don't even know why it's so expensive. So I think that's a great category because 1, you only have to buy really 1 vial of sperm. You can do this. And then 2, your partner can even carry for you. So now you both are carrying in the pregnancy. So I think it's an amazing opportunity for same-sex couples. But I do think there are some people who do it that probably aren't good candidates. There's one other interesting candidate I think about too, is people who make very few eggs.
Mm-hmm.
And I always wonder, like, I know IVF is better, but if they only make 2 eggs or 3 eggs in IVF anyways, would they benefit of doing a whole bunch of these over and over? So if they can do, let's say, 4 IVCs for the price of 1 IVF, even if you're making 2 eggs, that's 2 times 4 versus 2 times 1, And so, I don't know. What are your thoughts? I know, again, we also are a place, we don't push this at all. It's just something as a option for patients. What do you think for the future of like kind of fertility?
Yeah, no, I mean, I honestly I've always been really excited about IVC, but the big thing that they have to continue proving, the company, in my opinion, is value. They have to create value for the right group of patients, because obviously if it costs the same thing as IVF, well, there's no reason to go comparing studies and everything. We know IVF is going to work, at a higher success rate in a controlled lab with possible PGT testing and all these things. But I think that it's a really, really wonderful option. And I think that our world is evolving so rapidly in fertility. And as much as we want to continue getting deeper and deeper and understand more and more of the really nuanced basic science, I think we're at a point where we have to improve access. We have to create more opportunities for people to have different choices that are accessible to them. And I think this is, another opportunity that for the right person has increased access. And so that's the part of it that makes me very excited.
Absolutely. Ari, I know there's some other questions here coming in.
Yes, we have Julie. She submitted a question on Instagram. She asked, what is the success rate of transferring a 7-day embryo?
Sam, why don't you jump with that one?
Yeah, no, absolutely. I mean, so there's a lot to consider here. So just to take a step back, generally speaking, kind of modern IVF, let's call it, we grow embryos out to what's called the blastocyst stage. And they can develop at slightly different speeds. They can develop into kind of that blastocyst at the day 5 stage or the day 6 stage, or sometimes they're a little pokey and it takes them 7 days to get there. And what we know from a lot of the studies that have been previously done, both internal to specific labs as well as big published studies, is that on the whole, day 7 embryos implant at a much lower rate than a good, let's say, day 5 or day 6 embryo. There's kind of the basic philosophy is like, well, there was a reason it took them a little bit longer to grow. That's one part of it. The second part is this idea of genetic testing. So, I think the common thinking is that once you do the genetic testing, all embryos are created equal. Life is great. But unfortunately, even when you genetically test the embryo, and it is a normal embryo, there's a big difference between a day 5 embryo that's a high quality and a day 7 embryo that's a kind of even, let's call it mild or moderate quality. quality. And that difference can be, 30% for the day 7 live birth rate, up to 70% for the good day 5 embryo. There's more nuance to it. It's not like, doesn't boil down quite that simply, but let's say those are general guardrails for it.
Yeah, and I'm sure at CCRM, when you were there, I mean, you constantly look at your data. We look at our data too. Your point's well taken. I mean, we know that if you look at day 7 embryos and you test them, more of them are going to be abnormal than usually day 5 or day 6 embryos. And I was just on the podcast. I was just making a comparison to this of like someone going through high school. Everyone graduates, but the guy who takes 4 extra years to graduate high school, you start to question about, okay, how good is that guy if he took 4 extra years just to get through this? And so the same thing, why is the embryo taking longer? And when we looked at our data at our clinic, we actually stopped freezing day 7 embryos if they weren't tested. And the reason why is the pregnancy rates were so low, sometimes even under 20%. We've actually looked at, when you look at the lowest end of the embryos, like, in our category would be CC, other places that might be their, fair pores. We found there was almost no pregnancies. I mean, it was just so rare. A lot. And when I say no pregnancy, I mean, they would have a chemical pregnancy, but with it, it would never make it to live birth. And so we actually switched to only doing day 7s that have been biopsied. And even then, the difference between, even like you said, the A, the B's, and C's, there's a difference. And even our CCs had very low live birth rates. And so we even opted to not even freeze those anymore if it's a C travatherm because of the low live birth rate. So I had a conversation recently with a patient who paid a lot of money to get donor eggs, and they have a guarantee, and they had a day 7 embryo. And they said, well, that meets the guarantee. And I was pissed. And I called them up and I said, this is ridiculous. How can you sit there and say that meets your guarantee? And they're like, well, it's euploid. I said, but we all know, everybody knows that it's lower, the chances. Yeah. So I said, so if you're not freezing an embryo that's bad quality because it's a lower chance, then why would you count it as your guarantee? I said, listen, if they get pregnant, fine, no harm. But if they don't, how can you call it the guarantee? So yeah, I think there's still a lot we have to learn, like you said, but yeah, I mean, day 7s, there's definitely a chance. I tell people probably between about 30 and 40%, but it just depends on that quality embryo. So, did you guys do day 7s at your previous clinic?
Yeah, exactly. So it was a very, kind of a very selective group of day 7 embryos, much like you said. They would, be genetically tested. And the results were still, like you said, really, very, very modest or kind of low, just like those exact numbers that you said. And it has just so much to do with the embryo at that stage. And so, but it certainly was one of those things where if the embryo showed really poor quality, it wasn't biopsy. It just wasn't even biopsy. There's no sense in kind of torturing an embryo to biopsy it, to, hope that it will survive the thaw and do all these things, so.
Have you ever, before we jump to the next question, one thing I find interesting is that when women are more mature, so like, let's say someone's like 48 or 50 or something, and they get a normal embryo, a euploid embryo, we know the pregnancy rates are significantly less than someone who, let's say, is 42 that has a euploid embryo. And I only know this because one of the companies we use, Progenesis, we actually get to see data from all the clinics, and we can like use filters and figure out, and you see the drop as people get older. And so I've always, in my mind, the way I've always thought of it is that, it's not perfect, this testing we're doing. We're looking at large chromosomal problems. And we know that as we get older, there's a higher chance there's going to be small problems that are maybe not being picked up. I just wonder what your thoughts were on that, because that's one thing that in the beginning we thought all were the same. They're all euploid. And now we're realizing, they're not all the same.
No, not at all. I mean, I completely agree. And, there are so many factors that go into that, same embryo, right? You're looking at an embryo that's let's call it a 5AB on day 6, and it's between a 30-year-old versus a 40-year-old woman. And those are going to have, different success rates. And it's because, there are different processes that are happening just inherently to these embryos, and it's definitely something that we see now. The other part of it is, well, the pregnancy rates are still pretty good. You have a 5AB, day 5, day 6 embryo at 40. I'm feeling pretty good about that. So, I think there are some differences, but I think that in the whole, the process, it still works, and those differences aren't colossal. I think once upon a time before PGT, when you were doing an embryo transfer, you might have seen a threefold difference if you were just transferring a single embryo in those two groups. And now that gap has really narrowed.
Yeah, absolutely. Yeah, and the one that we did, the ones I've seen are like usually after 44. That's usually where you start seeing a real decrease in
Yeah.
almost like that same gap you talked about in the past.
Mm-hmm. Mm-hmm. Yeah, and that's hard, and that's that goes back to that theme about reproductive lifespan that I'm very interested in, is how can we kind of extend that reproductive lifespan a little bit, and then use the tools that we have currently.
One thing that's interesting too is, and I'm a little bit more mature than you, but we've been around for a pretty long time. When I first started, there really wasn't that much PGT. I mean, it was done, but there wasn't that much. As you know, in 2000, I think it was the 2004, maybe somewhere around there, where ASRM came out with our guidance to not do it anymore because there was actually a lower pregnancy rate doing it. There were some problems, so it kind of fell out of favor for a while. And then obviously, when they had better techniques, it came back. And so when someone didn't get pregnant, it was almost easier for a patient to accept it because they're like, okay, the embryo was probably abnormal. And one of the things that is harder today with PGT is that when it doesn't work, it's almost impossible to understand why from a patient standpoint. I try to explain this to them because they've never been in our shoes. We see hundreds and hundreds of these transfers, and we know that even a euploid, beautiful looking embryo doesn't always work.
Yeah.
But sometimes I feel one of my jobs is trying to explain that, like, how this perfect embryo doesn't work. And I feel like sometimes it's harder from people. I wasn't sure if that's kind of similar experience you deal with, now that it's not like the old days of, oh yeah, it was just an abnormal embryo. I'm like, okay, then try again.
Yeah. I mean, totally. The stakes feel like they're so much higher because we go through this one tool. The reality is it's not a perfect tool. It's good. It adds benefit to getting a little bit more efficiency out of each embryo transfer, but it is far from a perfect tool. I mean, even the very, very best embryos, will still kind of fail 30% of the time. I mean, that's a really big number, actually. And so there's a lot going on in the background that I would say just is not completely resolved or uncovered. And I think it is hard. I think like as a doctor, it is really hard to go through a failed cycle, and you've tried to do everything. You've added the PGT testing, you've done all these things. And that sometimes it's just biological luck. And there was an interesting paper, and it's been a topic of conversation about this idea of, is recurrent implantation failure a real thing, right? You put two, you do one cycle and you put a euploid embryo in, and then you do another cycle and you put a euploid embryo in. They both fail, and you get the label of recurrent implantation failure. And the reality is that just kind of like an anomaly, like a mathematical anomaly, right? You can flip a coin twice and never get heads, of course. And this is a little bit of that similar process. It doesn't mean that there was actually something wrong with how the process went. It could have been that everything was perfect. It just didn't work that time. And I think that's a really hard thing to live with, both as a doctor and as a patient, I think.
Well, it's a scary thing, right? I mean, I don't have a uterus, but if I did, the scariest thing in my mind would be, oh my God, my uterus can't hold a baby.
Right.
I mean, I don't have one. I think I'd be afraid to death about that. And so it's kind of one of those things we're worried about already. And then when it doesn't happen and you see so many other people get pregnant, you start thinking, is there something wrong with me? I do agree with you. I think that gets thrown around too fast. I think you have to look at the parameters and say, well, was it PGT? Was it not? That's the benefit, I think, of when you do PGT, is you can at least say, okay, it's not due to genetics. Now we need to look somewhere else. We know what the statistical chances are. Do we have to look at ERAs? Do we have to look at receptiva? Do we have to look at all those different things? But yeah, it's like I said, that's one of the hardest parts of my job is when it doesn't work. You feel just so guilty. And I know you know the feeling of that just horrible guilt of, could I have done anything different? Like, I wish I could, but you're right. There's just some things that are out of our control, and it could be just something biological. Anyways, I'll let Ari come back. I know we didn't give her a chance to tell us some other questions.
Yeah, we have about 2 more. Did you guys talk about the successful transfer of a rebiopsied embryo? Did you guys touch on that?
We have not.
Okay.
Yeah,
That's Julie's second part of her question.
You want me to start?
However, yeah, go for it. Yeah.
Yeah, so this one, I feel like we never give any answers here. We're always like, well, it depends and stuff. And I think this is one of those things again where there's a guy named Richard Scott who is a pretty big name in our field, and he does lots of studies about PGT. And so he's actually looked at this about, would a rebiopsied embryo have a lower pregnancy chance? And there's been other studies too that have shown things that where it shows there's lower, and then there's some that said it's the same. In his study, and it's a very good clinic and very good embryologist, they did not show an issue with a rebiopsied embryo. But the problem here is, what do you define as a appropriate embryo to rebiopsy? And this has been actually shown in studies that depending on how many cells you can take before you start hurting the embryo. And so I'm going by memory, but if I remember correctly, for a high quality embryo, so this would be considered like an A at our clinic, or B plus at the other clinics, so it would be considered like good, or it'd be considered, I think some other ones use like an A at theirs. You can take up to almost 12 cells and not hurt the embryo. But when you get to the next level, like a B, you're down to something like, 6 to 8 cells. And then you get to the lowest level, it's like 4 or 5 cells at the most. And then you start hurting the embryo. And that's because when you actually look at the embryos, there's actually fewer cells. So, I mean, there's so many more cells in the A embryo versus a B versus C. And so if you're rebiopsying an embryo that is a C embryo, you're definitely going to hurt the chances. I mean, you're going to see a lower chance. And it doesn't mean that it can't hurt an A embryo, but when you have more cells, there's less damage. But then I think it even goes down to the embryologist. I mean, different people have different abilities. And I think that's why some clinics have better rates than others sometimes, is that, you can be harming the embryo, even though I've even made the point in this in my podcast that, like, taking cells is actually very unlikely to hurt an embryo if you do it correctly. Just because there's so many cells, you're taking a small sample of a very, large thing. But with rebiopsies, there has been some studies that have shown that there can be decreased pregnancy rates. But like I said, the one I usually quote is the one from Richard Scott, and showed there wasn't when done on the correct embryos. And so at our clinic, we don't recommend ever rebiopsying an embryo with a C-choke ectoderm. If it's done once, even if it comes back inconclusive. Now, I make the argument that if you have some disease state that you're not wanting to do, well, then it's not unreasonable, because you're not going to use that embryo anyway. So even if you harm it, it makes sense to at least do the biopsy. But I'd love to hear your opinion on this, because like I said, the data isn't 100%, but I think it has to do with the quality. And so I want to see what you think about this.
Right. No, absolutely. I mean, this is like the really tricky part of about our field, where you have great people doing great research and they come up with completely different results or outcomes, right? And so I'm thinking back to a study that was done at Cornell at one point, and in that study, they actually showed that if you rebiopsy the embryo, the ongoing pregnancy rate was about 10% lower when you did that. Now, it's definitely true that there is that, there's other studies at other places that say, it depends if you pick the right embryo to rebiopsy, et cetera, it should be okay. And then there's like all kinds of like little nuances about, you know, why were you rebiopsying the embryo? Was it that the genetic output that you got was all over the place, or, you know, was there some contamination or something else? You know, so there's a lot of variables that actually go into that, even at that level. But I'm totally in the same boat. I don't think that rebiopsying embryo, first of all, it happens so rarely that you have to rebiopsy an embryo. And second of all, I don't think that, again, you're getting a lot of value added at that point. Where the value really comes is you got 7 embryos. You need to figure out where you start with transfers. And PGT tells you it's embryo number 1, 3, and 5. And, you know, that's where it really gives you a lot of benefit in order to be able to do the next steps of a, you know, single embryo transfer and other, you know, good things like that. But I'm not a fan of rebiopsying embryos, except in, you know, kind of edge cases, again, where we're looking at like single gene disorders and things that really, really, really have a big impact. And again, I think this is one of those things where, as a patient, it seems like, well, why wouldn't you do it? Just retest it, you know. But you have to thaw it, and you have to retest it, and you have to freeze it, and all of those little things are just a little bit of stress on the embryo at each point.
Yeah, no, I agree, and I think that's the point where you said, if you know you're willing to put it back anyways, you know, then why biopsy? Just put it back if you're okay with that. And because rarely are you going to have an embryo lead to something like a child with Down syndrome or something like that. I mean, it's still very low risk in most patients. And so you're right. Depends on what the purpose of why you're doing it. I know we're kind of getting short on time here. There is one question I see, Ari, that is about the natural FET. I don't know if we want to do that one, or maybe we can open the next show with that one and just talk about natural FET. Because I think it's a great question. You know, I mean, I think we could talk a lot about that. There's definitely, I don't even know there really are cons other than the fact that there's lots of cancellations and things like that. But I think that'd be a good one. I did see there was a comment earlier about does baby aspirin help increase follicles during stimulation? And it's funny, this question, because I've been through IVF twice. And the first time that I went through IVF, I had my wife taking baby aspirin, because the thought process was, you know, and this, I'm telling you as a patient, not as a doctor now, but as a patient, it's like, oh, well, it thins the blood, more blood flow gets to the ovary, and the ovary is going to do better, and we're going to make more eggs. So I was like, yes, let's do it. Then I went and actually read a reproductive book and, you know, looked at the data. I forgot the guy's name. I don't know why I'm going blank. He was in Texas, I believe. I cannot remember the name, but he wrote this book and he actually did the studies on this, and he showed it just didn't make a difference. And so the second time my wife went through, I did not put her on baby aspirin because it just didn't show up. And so I was wondering your input on that. I mean, I kind of tell people, like, listen, I don't care if you do it. It doesn't show really any benefit in that situation. But what's your thoughts on that?
Yeah, I agree. I mean, I think this is one of those things where you're like, is more necessarily better. And this is like, you just keep piling on like, oh, this is good, and this is good, and this is good. Well, you know, aspirin still has some side effects and some risks. And even though it's like a baby aspirin, they're very small, et cetera. I mean, I wouldn't say I'm against it. I'm not strongly for it. I think it lives in an area where, you know, I don't think it does enough benefit to kind of warrant its consistent use. But, you know, you did the real life experiment. I don't know. I defer to you on this one.
That's why I thought it was a great question. I'm like, oh, it's the thing I thought. And I'm, again, my wife and I, we're like, it can't hurt, you know, but then the second time, you know, I knew the study then. I was like, oh, it's not worth it. I told her, don't take it.
You're keeping us hanging here. What was the result of that IVF, of those IVF cycles?
Well, so the first one we did it, we had success. The second one we never did it. It took us multiple IVF cycles and we could ever actually get to retrieval. But when we got the retrieval, we had success. So I tell people all the time, like, for the actual retrievals we did, we always got pregnant every time. It's just that it took us a while to get to the retrieval on a few of them, lots of cancel cycles and stuff. So yeah. So I mean, look, it worked both times. So It's probably just my wife is awesome, and that's all it is.
Well, determination does definitely go a long way around here.
Yeah, absolutely. I always tell people, if you're willing to keep trying, eventually you'll get there. Um, I know we have a couple questions there, but I think we're gonna end it for tonight. And then what we'll do is, Lauren, I see your questions there. We'll pull that over to our next show, and we'll talk about that. And then Jackie, we'll talk about your natural FET question next time. Anything you want to end on, Dr. Salem?
No, this was great. I really enjoyed it. Would love to see some more people like come on and ask us their hard hitting questions, and really excited to do this the next time.
Yeah, I mean, like Lauren's question here, it's a great question. It's actually, if an immature egg matured 1 to 2 hours later, what's the chance of result in live birth? I mean, that's not even something I would even think about just talking about. So those are just great questions. It allows me to have a different view of what people are thinking. So I'm sorry I'm not answering it tonight, Lauren, but we will answer it on the next show. We'll post that on the website. And again, we love people to come on the show too. Don't be afraid. We won't bite you.
Awesome. See you
Ari,
all.
thanks as all the time, Ari, for always doing this and running everything. We really appreciate it. You are more important to the show than we really are. So thank you.
Of course. And just like Dr. Amos said in Salem, if we did not get to your questions, I know we have some on Instagram as well and some from YouTube. Please keep submitting them. We'll keep them in a little archive, and we'll make sure to have them in the future shows so they will be answered.
Well, thanks, everybody. Thanks, Dr. Salem.
Thank you. Take care.
You too. Bye-bye.